Hi everyone. So in our journey of bacteriology, we have definitely come a long way, and now we are here with our discussion of MRCS. What is MRCS? It's the bacteria which do not stain well with grams. So which are not going to be, I'm not going to call them positive or negative. They're just the ones which are gram poor. And what is MRCS? The M stands for mycoplasma. Mycoplasma is something I'll be dealing in the miscellaneous bacteria chapter. R is for rickettsia. Again, they are gram poor. C for chlamydia, and S for spirochetes. So I'm actually beginning with my discussion over here with spirochetes because that is what worries the students a lot. So yes, MRCS are the ones which do not stain with the gram stains. So now let's move forward. When I talk about the spirochetes, I want to first explain the meaning of the word to you. So spiro definitely means spiral, and chete means hair. So this is going to definitely be something spiral and very, very thin like a hair. Okay, so let me show you the classification. This is the classification that we have of spirochetes. We have the very, very famous Treponema, then we have Borrelia, and then we have Leptospira. How do I differentiate? T for T. So Treponema is the one that is going to have very, very tight coils. You can see the spiral, it's very tight. You know, it's so tight that it has started looking somewhat like a nail or a screw, isn't it? And that is how I've learned it. Because it is very, very tight and looks like a screw, what is the motility? It's the corkscrew motility that it has. So simple, the one that looks like a screw is going to have a corkscrew motility, that is T for Treponema, T for tight. Now we come to Borrelia. Now Borrelia, I will teach you in a while, has everything la, lu like that. There'll be louse, there'll be Lyme fever, there will be something called lashing motility. So all LLL things will come that we'll study in a while. But please note that Borrelia is something, like I told you, has lashing motility. Why? Because look at the coils. They are definitely gonna be loose coils. They are not the tight coils. So simple, Borrelia is going to have LA for lashing motility because it has loose coils in it. Finally, coming to Leptospira. Leptospira is just motile. There is no name given to it, just a motility it shows. But can you see this is differentiated because the ends are hooked. Leptospira has hooked ends. So how I have learnt it is Leptospira is lapeta hua. Lapetna means folded, na? So Leptospira is lapeta hua in Hindi. That is how I've learnt it. So lapet liya, that is folded. Simple. Treponema has tight, T for T tight coil. Borrelia has loose coils. Leptospira is lapeta hua. Treponema has corkscrew motility, Borrelia has lashing motility. But you know, when all of these are motile, whenever I say something is motile, you automatically agree that, ma'am, it must be having a flagella. Now the difference over here is that they don't have a flagella. You will never see a flagella coming out like this or a flagella coming out like this. No, go back to your general microbiology chapter. I have taught you that this has an endoflagella, a flagella that is hiding inside. You can call it an axial filament or an endoflagella. Where is it hiding? Do you remember from your general microbio chapters? That is in the periplasmic space. It is hiding in the periplasmic space, and that is what is important about it. So over here you will easily be able to see that there is a flagella which is coming somewhere in the periplasmic space. Over here also you can see that this is the periplasmic space, and here I can see this dot 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 flagella hiding. It's not going to come out, it's going to stay inside. So endoflagella. Moving on to classification of the first member, that is Treponema, and I know all of you are aware of Treponema pallidum because that causes the most important venereal syphilis. Venereal syphilis means the one that is sexually transmitted, right? Apart from that, so this is the STD wala. But first I'm going to finish off the chota wala one. That means we have non-STD. That includes Treponema endemicum. Of course, that is going to cause endemic syphilis. So simple name. Endemicum causes endemic syphilis. Then we have Pertenue and Cariatium. So remember, P is not for P. Again, if you by now have studied path and micro with me, you know that my favorite mnemonic, and somehow that fits everywhere, is P is not for P. So that means that if they ask you who is causing pinta in yours, so P is not for P. Pertenue is causing yours and Cariatium is causing pinta. So remember that P is not for P. Repeating, Treponema pallidum, everyone knows, sexually transmitted syphilis. Endemicum, endemic syphilis. Treponema pertenue doesn't cause pinta, it causes yaws, and Treponema cariatium causes pinta. So a quick review of these three things. This is only important if you're trying to get better marks in micro, because we know that yaws as a disease has been eradicated from India also, right? So yaws, endemic syphilis and pinta. For that, I want all of you to learn a yonic kid called Pintu. So we have a yawning kid named Pintu. So firstly, the yawning will definitely mean that I'm talking about a disease called yaws, and Pintu will definitely tell you that you're talking about a disease called Pinta. So I'm currently talking about yaws and Pinta. This means I'm talking about yaws and Pinta. So you can see Pinta over here. How do you yawn? You always put your hands out, na? You stretch your hands. So yaws will always remind you that kuch to extremities wala thing is there. Kid will remind you that this is occurring somewhere in children. And also when we yawn, guys, what do? If I am yawning, it's contagious, right? You will also start yawning. And once I yawn, then I yawn multiple times because I'm too bored. So yawning is associated with relapses. This means yaws is going to be associated with relapses. Now let's start doing this. I told you, in fact, this entire thing, not just yaws and Pinta, even endemic syphilis, all of them are in some stage of childhood. So that's why I said it's a kid. All of them are in childhood. Okay, which of them is going to have relapses? I told you yawning is contagious. It's going to happen again and again, right? So we have yawning, that is going, yaws is relapsing. Others are not going to have relapses. Okay, coming back to yaws and Pinta. I told you, when Pintu is yawning, when Pintu is yawning, he's stretching his hands out. So who is going to have a problem in the extremities? The extremities wala problem will be yaws and Pinta, whereas endemic syphilis is, think what is left. Yawning mein Pintu has extended his hand, but can he yawn without opening his mouth? So endo, inside his mouth, oral. Endemic syphilis is going to be oral lesions. And if it is oral lesions, now I will ask you, how are they spreading? So please remember that the ones which were happening in extremities, yaws and Pinta, of course extremities mein skin hai, so they are having skin to skin spread. And endemic syphilis is something which is happening in the mouth. So in the mouth it is associated with kissing. Finally, coming to the features, please, this if you can learn, that yaws is associated with ulcerative papilloma, Pinta is associated with a non-ulcerative papule. Not very important as a feature, but what you definitely have to know is what I can repeat. When I said yaws and Pinta, when you yawn, you put out your extremities. So this is the one that occurs on extremities. This is the one that is skin to skin. Endemic syphilis is going to happen inside the mouth, and that is associated with kissing. All of them are children, right? And which is the only one relapsing? So yawning is going to be again and again, yaws is going to be relapsing, right? Now finally, these three are over for us. I can concentrate on the main one, and that is Treponema pallidum, that is venereal syphilis. Means we are talking about syphilis, which is sexually transmitted disease. So your first question is going to be, yes, this is venereal syphilis, this is sexually transmitted. The incubation period is very interesting, easy to learn. 9 to 90 days, it has quite a long duration. 9 to 90 days is the incubation period that we are going to have for syphilis. And how many stages do we have? We have primary syphilis, secondary syphilis, tertiary syphilis, and that is what I'm starting with. Now, we all know sexually transmitted disease means we are having a genital ulcer here. But note, when I say syphilis, your mnemonic is going to be syphilis. If anyone asks you that what is the ulcer and what is the lymph node, you will say everything is painless. So now tell me, this lesion is known as a hard chancre or Hunterian chancre. What is that meaning? Hunterian, firstly, is the name of the scientist. Hunterian, basically, I'm no need to write this, only for knowledge history purpose, I'm telling you. Hunterian is the one who distinguished it from gonorrhea wala, because gonorrhea is also a genital infection. So Hunterian scientists defined it, so they called it Hunterian. But what do you mean by hard chancre? Hard basically means that it's going to be extremely indurated. It's going to be extremely indurated, and chancre tells you that there is going to be a genital ulcer. Now my next question is that this ulcer is going to be painful or painless. I've told you beforehand, everything in syphilis is going to be painless. So the ulcer is also painless, and so is the inguinal lymph node. Everything has to be painless in this situation. Everything is painless. Simple. Okay, what else? If I look at it carefully, is it giving that a little shiny glaze kind of an appearance? Because it is covered with a thick, glary, glazy exudate. That is also one more thing, and in most of the cases it is avascular. But your take-home message is it is a hard chancre, not a soft chancre. Why? Where did you study a soft, not chancre, chancroid? Where did you study soft chancroid? In bacteriology, you have done something called Haemophilus ducreyi, and I have taught you that crying, crying. So that is going to first be very, very painful, crying with a lot of pain. So crying with a lot of pain. And obviously people who cry are a little soft-hearted. That is what they say. Crying means you are soft-hearted. So soft hoga because crying with pain. And ducree-chancroid. Ducree-chancroid. So simple. When I say ducree, you say chancroid. You don't say chancre. You say chancroid for ducree. And crying hai, so this means you are a little soft-hearted. And why are you crying? Because you're having a lot of pain. So if this is soft, this becomes hard. If this is having pain, this becomes painless. Simple, opposite chal raha hai. This was about primary syphilis. Now you will ask me what is the healing aspect. So please note that this is basically going to heal in approximately 10 to 40 days. And this is going to leave a thin scar. That is one thing that can happen. But also what can happen is that the patient enters into secondary syphilis. Secondary syphilis means two. Now everything, listen to me carefully. Firstly, after approximately 3 months, this can happen of primary syphilis. Then these patients are going to suffer from condylometalata. Can you all see these nodules? Where are they present? At the mucocutaneous junction. Look at how I'm lighting it. Condylometu latu, which is occurring at the mucoq2 junction. Why did I say I'm putting in the word tu everywhere? Because you need to know these are features of secondary syphilis. So remember, condylometu latu at the mucoq2 junction is going to occur. Apart from that, so these are sorted. Condylometum latum. Now we come down to there are involvement of two hands and two feet. Of course, we have 2 hands and we have 2 feet. What is going to happen in those 2 hands and 2 feet? We are going to have these rashes, the papular skin rashes. So is everyone sorted with the 2 features that are going to take place in secondary syphilis? Number 1 is condylometu latu at the mucoq2 junction, 2. And the second feature is 2 hands and 2 feet are going to show you rashes. Secondary is done. Now after this, obviously next one you expecting tertiary, but sometimes what can happen is patient tends to sleep off. Means suddenly all these clinical features are going to vanish, but that doesn't mean that the patient doesn't have syphilis. The serology, the tests are positive, but the clinical symptomatology is not there. This can be quite a dangerous condition, especially when a person is coming for a blood donation. He doesn't have any symptoms, but his serology is positive. He has syphilis. So this can be a sleeping phase which will later on wake up and can be a problem. But yeah, you were expecting the tertiary syphilis. So here we have tertiary means that now different organs are going to get affected. Number 1, there are benign tertiary syphilis. Benign tertiary syphilis means this results in the formation of gummas. Gummas are seen in the bone and the skin. You can see these gamma lesions over here. And I want to ask all of you, G for gamma, and I'm asking you a question from pathology. Microscopically shows you what? G for granulomas. If you remember, go back to your patho lectures. I have taught you gammas show you granulomas, and what is special about this granuloma? That their plasma cells are in abundance. This one word I have taught you in pathology also. So benign tertiary syphilis done. Other than that, there's a heart problem, cardiovascular problem, there is a central nervous system problem. So dono mein three things because we are talking about tertiary. Let's get going. Cardiovascular. Number 1, there is obliterative endarteritis of vasa vasorum. You know what is vasa vasorum? Vasa vasorum is artery supplying the artery. So for example, if this is a blood vessel, this also needs blood. So there are going to be tiny blood vessels which are supplying blood to it. So it's blood supply of a blood vessel only. Those chota blood vessels are known as vasa vasorum. These ones over here, the ones in pink, and they show you obliterative endarteritis. Apart from that, there are aorta. Everything about aorta is involved. There is arch of aorta, ascending aorta, aortic valve, everything aorta is involved. So when I talk about ascending aorta and arch of aorta, you will say they will show aneurysms. And when I talk about the aortic valve, that will show aortic aneurysm. So everything about aorta is definitely going to be involved. Now we come to neurosyphilis. So very important things coming up. Firstly, it causes aseptic meningitis. I hope you remember. Aseptic meningitis was also seen with TB. Very important. So aseptic meningitis. Secondly, it causes stapes dorsalis and it also causes GPI, general paresis of insane. And as per medicine highlights, you know that insane word has been removed and now it's just general paresis only. So remember, aseptic meningitis, stapes dorsalis and GPI or general paresis is what is the neurosyphilis. Now before I go on to the others, can you tell me out of these, so kya tha? Cardiac involvement, neural involvement and gammas. Where do you see the tree bark appearance? This is a question which I'm asking you from of course pathology, but let's see how many of you have revised my pathology lectures, vascular chapter before coming here. Which of them shows you the tree bark, or I'll put it easy for you, tree bark appearance is seen in aorta. So of course it is seen in tertiary syphilis, right? Tree bark aorta, because I told you everything is aorta, right? So tree will always remind you of 3. So remember, tree bark aorta is seen in which syphilis? It is seen in tertiary syphilis. Okay, but I'm again and again saying syphilis happens because of sexual transmission. You'll say, is there any exception? Someone has syphilis because of Treponema pallidum, but not sexual. Yes, non-venereal. Who will get non-venereal syphilis? Someone who's one of probably us, healthcare workers, because we are dealing with the patients. Maybe we are dealing with the patient with genital ulcer, but tell me, if it is a non-sexual route, see, till the time it was a sexual route wala syphilis, it was happening on the genital regions. If it's a non-sexual route, like in healthcare workers, you are touching and dealing with the patient with your hands. So where do you think the chancre will be? The chancre will be on our hands also. So we have to be very careful. This means the chancre is going to be at extragenital sites. The chancre is going to be at extragenital sites. Also tell me, that is because it basically depends which part of the body is touching it, right? But if someone gets it via blood transfusion, then no part of the body is touched, no part, right? There is no body to body touch. So this means there is not going to be any primary chancre only. So these are some exceptions. If it is a non-venereal route, for healthcare workers, you check out for extragenital sites. For blood transfusion patients, there will not be any primary chancre. What is another route? What is the mother? The mother is going to give the disease to the child, of course. That is a mother to child transmission via the placenta, of course. Transplacental, how is it going to manifest? It is going to manifest in the form of bony lesions, guys. The child is going to have osteoperiostitis. And do you know some classifications? What happens on the nose? Come on, you know this appearance from pediatrics very well. There is a saddle nose, and what is happening in the tibia or the shin? There is a saber shin. So basically we see that all the bony manifestations come up if it is a mother to child congenital syphilis involvement. Okay, now let's move forward. We are up for the lab diagnosis. What specimen will you take up? That depends whether you're in primary, secondary or tertiary phase. If you're in your primary phase, you will go in for the genital ulcers. If you are in the secondary, tertiary, if it's involved the heart and the nervous system, then you will go in for blood and CSF. So depending on the stage we do. And which microscopy? Come on, you've seen this picture earlier also. Which microscopy? Because they are very thin, we have to use dark field microscope, isn't it? Dark field microscope. Why? Because this is a very patla sa. This is a very thin organism, and for thin organisms we use dark field microscope. Okay, so what is the movement? It tends to have a forward backward movement. That is the kind of movement it shows you. A forward backward movement, and not only is it moving forward backward, it can bend at 90 degrees. It can also show bending at 90 degrees or right angle. So simple, very patla organism. That is why I had to look at it on dark field microscope. Will keep moving forward backward and is going to bend at 90 degrees. Bichara Spirochetes is like a first year fresher. I remember when we had just joined MBBS and at that point of time ragging was not so strictly banned as it is now, and I feel it's good that it's banned. But yeah, there was a basic healthy interaction that all of us used to have with our seniors, and there was a rule in our college, we had to become Spirochetes. Whenever we used to see a senior in college, be it a MBBS senior or MD or any senior, we had to first move front and back in front of that senior, and then we had to bend at 90 degrees and wish that senior. That was just a rule in our college, and just I would say healthy interaction. There was nothing as ragging as I can call it. But yeah, since that time, ever since I've read Spirochetes, I've always been reminded of my fresher days in MBBS. Anyway, so they move front and back and they bend at 90 degrees. Okay, but if you say that no, I don't have a dark field microscope, put some stain and let me know. So whenever you want to make something thick, for example, if a bacteria is very thin and you can't see it under a light microscope, you will start depositing something around it. You will start making it wear very thick jackets and thick clothes so that it looks mota, it looks bigger. And that is what you're doing. You're adding a lot of silver. What are the silver stains? The silver stains are Fontana's method and Levadity's method. Remember, F for F and TI for TI. If you have any films, means any FNAC, smears, any films are given, you will use Fontana. And if you have any TI for tissue samples given, you will use Levadity. So simple, guys. I hope you've understood. You will use F for Fontana when films are involved. You will use Levadity tissue samples ke liye Levadity, and they will look black like this, because I think this much of information by all of you know that it gives a black color. Done with this also. So if you have a light microscope, how can you see it under light microscope? By adding all these colors. If you have in dark field microscope, then this is how you're going to look at it. But you cannot escape the serology. What is the serology? There is a non-specific and a specific. Of course, I'm going one by one. Let me tell you about this. Please note, Wassermann is a complement fixation technique which hardly anyone does. I had mentioned Wassermann is a complement fixation technique way back in immunology chapter also. Cahan test is also a tube precipitation test. Again, something which is not done nowadays. What do you have to know in the non-specific tests are VDRL and RPR. We are going to understand them, see their photos, do their differences and everything about it. Then let me tell you, whatever I'm doing till now still remains non-specific. Then I'll tell you this one slide about specific. So abhi ke liye, Wassermann complement fixation not done. Cahan's is a tube not done. VDRL and RPR is done. So what is VDRL? VDRL name was given because of Venereal Disease Research Lab. This is named after a lab, Venereal Disease Research Lab, and this is basically done on slide. This is a slide test that is performed. You can see a very thick slide with these wells inside it. Hai na? So I've shown you the side view so that you can see that, yeah, it's a glass slide. Okay, so VDRL is done on that, and now you'll say that at the end of it, ma'am, at the end of any serological testing, means you're trying to find out antibodies in the patient. Means you will have to do an antigen-antibody reaction, and that is how you will do the testing, right? So if you are having antibody from the patient, means you've got a sample from the patient. You know, let me tell you, VDRL is going to be very, very difficult in real life. That is how we used to learn it. VDRL is very difficult to do in real life because there are so many steps involved. So listen to me. You take patient sample, you can't use it as it is. So whatever you've taken from the patient, you will have to heat inactivate the serum. Fine. After that, you will say, okay, koi bhi antigen dal do? No, you have to put a special antigen known as cardiolipin antigen. I know many of you will ask me, what is cardiolipin antigen? So the mnemonic for cardiolipin antigen is cardiolipin. Why? Because please note, cardiolipin antigen has Li for something to do with lipids. So it has the lipid extract of beef heart. Okay, then it has another L that is going to be lecithin. And it has another L, another lipid, which is nothing but cholesterol. So basically, cardiolipin, cardio to tells me that there must be someone's heart involved in it. Of course, beef ka heart is involved in it. And lipin tells me that everything is going to be lipid. That means there is a lipid extract. So if I break it, there is lipid from the beef heart. Okay, that is one lipid. Other than that, lecithin is also there. Other than that, lipid cholesterol is also there. So I will need that complicated cardio. Bahut zyada difficult na, very difficult in reality. So remember, cardiolipin antigen is needed. Then you will take the patient's blood, heat inactivate it. Then you will mix it, and then you will get clumps. You will get to know, okay, he or she has the antibodies. So I realized that this is very, very difficult to do. Further beyond that, you are telling me, itna kuch kara, you did so much of effort, and then you are saying it's a non-specific test. It's not even specific exactly. It's gonna give you a lot of false positive. Everyone who gets a VDRL positive is not syphilis positive. What is VDRL ka false positive? Very important question in medicine. Long list. Students mess up. I've given you a very simple mnemonic. If someone says, when is VDRL gonna be false positive, the mnemonic is VDRL false positive. So listen to this. V for viral infections like infectious mononucleosis. D is going to be for drugs like procainamide. R is going to be for rheumatic fever. VDRLL, lupus and leprosy. So please remember, viral infections also have antibodies. Drugs like procainamide can ship drugs. They can definitely cause antibodies. Rheumatic fever has antibody. SLE, lupus, so definitely has a lot of antibodies. Leprosy can also produce antibodies. So I have analyzed VDRL, so I have done. What is FP? First trimester of pregnancy can also sometimes show you false positive VDRL. So please note that this is early pregnancy. I have learned early pregnancy ki jagah, I have learned first trimester, so that my mnemonic is complete. First trimester of pregnancy can also show you. Simple na? Good mnemonic, I hope, yes. So I'm probably praising myself. I hope you are doing that on the other side too. Viral, drugs, rheumatic, lupus, leprosy and FP, first trimester pregnancy. So itna kuch kara, but it turned out to be false positive. So now you will say that VDRL has a lot of issues. So can you compare it with the next method, and that is RPR. What is RPR? RPR is rapid plasma reagent. So now whatever you studied for VDRL, let's do ulta. Tell me, in VDRL, what all samples could you take? Any sample of your choice. VDRL, you could take blood, you could take CSF. RPR has a problem, all except CSF can be taken. So tell me, which of these will you use for the diagnosis of neurosyphilis? देखो, neurosyphilis मतलब something anyway, neuro something, neuroanat, neuroradio, neuro something is always complicated. That means that neuro wale ke liye you will have to use the complicated test. If they ask you what is the investigation of choice for neurosyphilis, you will say, okay, neurosyphilis is anyway, neuro matlab complicated, let me use the very, very difficult test in reality, that is VDRL. This is sorted. Okay, now tell me, in VDRL, what were you going to do? Did you need to preheat everything? You had a problem. You had to preheat the serum, hai na? RPR mein you don't have to do that. In VDRL, did you have to prepare that cardiolipin antigen and within 24 hours you had to use it? Yes, I had to prepare that cardiolipin antigen. In RPR, you can directly use the antigen. You don't have to prepare any cardiolipin antigen. Next, did you have to pick up a slide in VDRL? I told you that glass slide, na? I showed you that picture of a glass slide. So you had to slide hai, matlab you will have to look at it under the microscope. So that's another problem. A microscope also you need. RPR says that no, I'm a simple card test. I'm a rapid test. My name is only rapid. I'm a rapid test. I will not need any kind of microscope. So look at this. If they show you this kind of a paper, a card, and they have written RPR carbon under it, you know they're talking about the rapid plasma reagent test. So now tell me that RPR is saving so much. Rapid hai. Neither do I have to do anything to the patient sample, nor do I have to do anything to the antigen. I don't need a microscope. I don't need a slide. So obviously, when you are being given so many facilities, it's going to be costly. And VDRL mein everything to ma'am I am doing. I am treating the sample. I am preparing the antigen. I am only looking at it under the microscope. Sab mujhe hi karna hai, to what will the company charge for? It's going to be slightly cheaper. Just a story so that you can learn it. So remember, VDRL is a very, very difficult test in reality and RPR is a very, very rapid test. But all said and done, all of these were falling under the non-specific variety, because now I go on to the specific tests. I know first their names are only so deadly, and I also know there's a lot of controversy around it. So I'll sort that out. The specific treponemal confirmatory test. What is that? FTA absorption. So that means, first please everyone write the full forms with me. Fluorescent treponemal antibody absorption. So see, every word will tell you treponemal antibody. Fine, I'm testing antibody by something known as absorption assay. By something known as absorption assay. So FTA absorption is going to be the first thing. Second, what is TPI? TPI stands for Treponema pallidum immobilization, and you have to know their full forms. You know why? Because then only you will be able to know my mnemonics. So Treponema pallidum immobilization. Okay, what is TPHA? Again, I'll write TP, so everywhere is Treponema pallidum only. HA is going to be hemagglutination assay. It is something to do with hemagglutination. So hemagglutination assay. And TPPA, Treponema pallidum particulate assay. So now there are a couple of questions which are coming up to everyone's mind, that please quickly tell me which out of these is said to be the most sensitive, which out of these is said to be the most specific, and which out of these is gonna be important for congenital syphilis. Which of these is important for congenital syphilis? So firstly, sensitive. Ab dekho, if I say who's sensitive, if I talk about someone who's a very sensitive, emotional person, you'll say, ma'am, that person absorbs everything in his system. Anything you say to him, he's very sensitive. He will take everything to his heart. So anyone who absorbs everything in his system is very sensitive. So what is the most sensitive test? FTA absorption is the most sensitive test. Thoda life lessons also we keep doing. Now, which is specific? Specific means more specific, only for Treponema pallidum, only cheering for Treponema pallidum. Specific means it's not gonna move and any other organism cannot make it move. It is immobilized. That test is immobilized. This means TPI is the most specific, followed by TPPA. So if you have to select one best, it is TPI, but still that is MCQs ke liye. You know why we don't prefer TPI? Basically, TPI tends to use live treponemes. It uses live treponemes, as a result of which we cannot use it all the time. That is why I've given you two options. If TPI is there, very good. If not, then we will go for TPPA. But what do I use for congenital syphilis? Now listen to this also very carefully. If you are given these four options, children are also very, very sensitive. So children ke liye bhi sensitive, absorb kar lo. So children ke liye also you will use FDA absorption. But if they give you an option between all of these, पहले तो I was only giving you these four options, so you ended up marking the absorption wala. But if I give you all of these, so remember for children now they are saying VDRL. Children are difficult, na? Very, very difficult to grow up children. So please remember VDRL is now coming across as a better technique than FDA absorption. Okay? So now I've tried to put in the most controversial, and don't come back to me saying, ma'am, either this was written, that was written, some other source has taught me this and that, because I've done ample amount of research on this from a lot of journals and I'm giving you the most accepted information. So yes, there will be a controversy. Be ready for that because we have so many studies going around it. Repeating, the most sensitive people absorb a lot of information, FT absorption. More specific, the immobilization one, but that uses live treponeme, so TPPA can also be used. Congenital syphilis, out of these four, it's going to be FT absorption, but overall the better test is going to be VDRL. Just one more question that I have. For doing all these confirmatory tests, what are the strains of Treponema that you're using? There is something known as the Nicole strain. The Nicole strain is being used for all of these tests. I hope it's okay. So let me take a test for you guys. It's a case of congenital syphilis. Till now they are saying FTA absorption test is the best, but now do you want to give a better test than that also? What will you fill in the blanks? Now even VDRL is considered better. Very good. This is done. What do we move on to next? We are going on to the treatment aspect. You know, it's a case of benzathine penicillin for primary, secondary, latent, all stages. But if you're going in for neurosyphilis, neuro is always going to be something which is more dangerous. So penicillin G is always preferred. Penicillin G is always going to be preferred. I hope you also remember that this can result in the Jarisch-Herxheimer reaction. This is something that I just wanted to correlate with pharmacology. So that could be a case over here. So I hope that's done. Treponema is done. What do we move